tough cases. What do you feel? Is there an interactive chat over here?
The chat is interactive, so these guys can reply.
Yeah. So what do you feel? There are multiple ring enhancing lesions which are appearing very T2 dark. Yeah, KR has said ring enhancing lesions. They are conglomerated. They are appearing T2 dark. Yeah, that's right. Brinda, you have said it as tuberculoma. So this is tuberculoma. So tuberculoma, I want to add to this that it has got four stages. First is the non-caseating granuloma, where the lesion appears very hyper intense on T2. Honestly speaking, I have never seen a T2 bright tuberculoma, so I'm not really sure about the first line. But regarding the second and third row, our case belongs to the second category, that is the caseating granuloma, in which the lesion is hypointense with a hyperintense rim outside on T2 weighted image, and it has homogeneous or a ring enhancement. We had got a ring enhancing lesion. Now the second one is also quite so the second so this does not show any diffusion restriction. Now the third stage is caseating granuloma with central liquefaction. In this, the lesion has a hypointense rim. This is very commonly seen and has a central hyperintensity. That is the liquefaction within the tumor. It may or may not show diffusion restriction, and it is ring enhancing. And the last is the calcified nodular stage. You could go through this article. This is quite an interesting article I just found before the presentation. Uh,
Arpita, we lost the presentation.
can you see? Is it?
No, we can.
Uh, I'll just log in again or what? What do
Yeah,
you
either you
think?
can read.
But I'm not able to find the reshare button. I
So
think
that
some.
green icon again at the bottom.
Um,
No,
is it seen?
you can rejoin then. Yeah.
Yeah, I'll come again. Yeah. Now is it seen?
Yes,
Ankita?
yes, now I can see.
Now it
You
is.
just need to go. Yes, now you're in the presentation
Yeah.
mode.
Is it a big screen now?
Yes, full screen, full screen.
Yeah.
The
Feel free.
case of 50-year-old.
Yeah. Yeah. Thank you and sorry for the inconvenience. So next is a case of a 50-year-old female with breast malignancy. So what is the diagnosis? It's again a very simple case. KR, no, it's not METS, it's classical for something. Yeah, Vrinda, you are right. SM, yeah, everyone almost got it right. So this is neurocystic Can you please tell me which phase of neurocystic this belongs to? There are four radiological stages of neurocystic. So which is this phase? That's right, Vrinda. It's colloidal vesicles. Smrita has also got it right. So, going to the next slide, we have the vesicular stage, where we see a hole with a dot appearance, and the lesion may or may not enhance, and there is generally no edema. In the second stage, which is in our case also colloidal vesicular stage, there is rim enhancement, there is a scolex, and there is some perilesional edema. Then you have a granular nodular stage where the rim becomes thickened and crenated. It has got crenated kind of margin, and due to reactionary elements secreted by the lesion, there is a lot of edema over there. And last is the nodular stage. What is this? Something related to the previous scan only. Multiple cystic nodular grape-like lesions seen within the cisterns with no Collects within the lesion, these do not show any enhancement, and there is some meningeal enhancement within the cisterns. Yeah, that's right. That's Resmos NCC. So Resmos NCC, they are within the ventricular system. They are of variable sizes and they lack scolex. The lesion also may or may not show any enhancement. And generally, what happens is NCC, they do not show any enhancement. Type of NCC, you could see cisternal type of some enhancement because of the irritation caused by the lesions into the subarachnoid space. Going to the next case, so see this scan very carefully. I'll show you multiple images, stack of images. Take it as a long case. 27-year-old male, imbalanced while walking since 3 months with progressive hearing difficulties. There are multiple findings. I'm starting from the bottom. Don't just stick to one finding, there are multiple findings. Yeah. Can you just mention where have you seen the lesion? You have mentioned the finding, but across what area? I'll just scroll again. Excellent. Yeah, I got it right. Who have said right, acoustic schwannoma. So some of you have got all the findings right. So let me tell you, there are 4 findings in this scan. I'll go to the contrast images now. Now you tell me what all you see. There are 4 findings. I'll scroll it again, the contrast images. So everyone got it right that there are bilateral acoustic schwannoma and this is a case of NF2. Definitely this is a case of NF2. What if the patient is having just a unilateral acoustic schwannoma? How do we say whether this patient has NF2 or there is no NF2? Is it mandatory to have bilateral acoustic schwannoma? So below the age of 30 years, if the patient is having just a unilateral acoustic schwannoma and first degree relative has a NF2, then the patient can be labeled as a NF2. If the patient is below the age of 30 years and has only one acoustic schwannoma and has other tumors like meningiomas, schwannomas at other places in the brain and spine, then it could be a preferably an NF2 case, not a confirmed. So apart from these two acoustic schwannomas, there are schwannomas along the fifth cranial nerve bilaterally. See this. There are schwannomas along the trigeminal nerve also. So there are bilateral acoustic schwannomas and bilateral trigeminal schwannomas. Then what do you see in the spine? There are multiple lesions. This could be schwannomas. This could be meningiomas. Oh, that's not ependymo. That will be within the intramedullary area. This is outside. This is extra medullary intradural space. And what is this? It's the same case going on. What is this? Where is the lesion located? That's also schwannoma. That's not hypoglossal. That's quite lower down. Yeah, Ria got it right. So this is in the carotid space. So Shubhi wrote it vagal schwannoma. Uh, Sujoy wrote it sympathetic schwannoma. How do you differentiate between a vagal and a sympathetic schwannoma? So this schwannoma is in the carotid space. That's right. Now, vagal versus sympathetic schwannoma. How do you differentiate these two? Look at this diagram over here. This is the carotid space. This is your internal jugular vein. This is your common carotid artery. So, if a lesion displaces both the vessels laterally, as seen in our case also, this will be a sympathetic trunk schwannoma. And if both the vessel, that is the common carotid artery and internal jugular vein, are displaced, that is splayed apart, then that will be a vagal schwannoma. So this one will be a which schwannoma? This will be a our case would be a sympathetic schwannoma, right? So yeah, this is a sympathetic schwannoma. Correct. Now this one would be which schwannoma? This is not from the case. I'm just showing it. So this is your common carotid artery. This is your internal jugular vein. So this is your vagal schwannoma. That's right. You all got it right this time. Very nice. Everyone is quite attentive. So about NF2, which is more common? NF1 is common or NF2 is more common? Which is more commonly seen? NF1. Ria got it right. Yeah, very good. So what all do you see? We see bilateral acoustic schwannomas, non-vestibular schwannomas, meningiomas, cord ependymomas, and schwannomas of the spinal nervule. What is the name of syndrome with multiple schwannomas not involving the vestibular area? Zero vestibular schwannomas, but there are multiple schwannomas everywhere. Yeah, schwannomatosis. That's called schwannomatosis. Very nice. Two, three of you have got it right. So going to the next case. This is a boy with extensive crying since 10 days and he is 3 years old. Tell me your findings. Again, there are multiple findings in this case. What all do you see? Sorry for the bad quality images, seriously, but you need to really see very carefully. Uh, so, do you see something over here? That's the lesion at the 7th 8th cranial nerve complex on the right side. Then there is some lesion or some deposit in the left cerebral hemisphere, and then there is a big, huge lesion in the spine. VHL, no, VHL. When does VHL manifest? This is a 3-year-old child. Would VHL manifest in a 3-year-old child? Myxopapillary ependymoma. It could happen, but not at this age. This is quite an early age. NF2. NF2. So the manifestations of NF1 are generally seen by the age of 10 years, and for NF2 it is generally seen by the age of 30 years. So this, again I am saying that this child is just 3 years old. This was a case of ATRT, atypical rhabdoid tumor, which is predominantly seen in the posterior fossa and is also seen in kids below the age of 4 to 5 years. Schwannomas do not happen at this age, Upasna. This is just a 3 years old child. Even with the syndromes, schwannomas do not manifest so early. Uh, Coming to the next case, this kid is 3 years old again. What do you see? I am just messing your brain before the match. You see a mass which is quite heterogeneous. There is some bleed within the tumor along the trigeminal area. Very good. Yeah. He wrote it as trigeminal schwannoma. So again, a schwannoma wouldn't manifest at such an early age. That's what I want to tell you again and again. So Joy, Shubhi epidermoid, you have written because it is showing diffusion restriction, right? But epidermoid does not show any enhancement. This lesion on the right side, if you can see, it is showing lot of enhancement. Yeah, Ria got it right. So this was a case of ATRT, and a differential could have been in this case rhabdomyosarcoma. So people are writing as Wnt also. Uh, for Wnt to go so superiorly, like so Bhuvan has wrote it very nice that WNT Wnt. So WNT Wnt is a type of medulloblastoma which are quite laterally placed, that is they go along the foramen of Luschka towards the CT angle. But what happens in those cases, they co-laterally, but they go inferior in the inferior direction. That is, reaching up. They go towards the foramen of magnum. Now, in this case, it is going quite superiorly. That is, it is going up to the Meckel scale. So this is a case of ATRT and a difference of the fifth cranial nerve. And meningioma, Akash, meningioma wouldn't appear before the age of 25 to 30 years. That's also not a pediatric tumor, meningioma. And a differential would have been a rhabdomyosarcoma in this case. Nobody thought of it, rhabdomyosarcoma, because that is also a round cell tumor and that will show diffusion restriction. And it is seen in young patients, like below the age of 5 to 10 years. So that would have been a good differential. Neuroblastoma metastasis can be a differential. Yeah, that's right, Tapas. That's a nice differential. It is again a round cell tumor, and that will show diffusion restriction. MPNST, I am not really sure whether it will be seen at such an early age. Again, next case to confuse you all. 7 months old boy. So Sadia wrote it as central neurocytoma. Central neurocytoma appears in young age, like 25, 30, 35 age group. Yeah, Tapas got it right. Choroid plexus carcinoma node that is seen at the atrium of the ventricle at this location. So this is in the third ventricle. Part of the lesion is enhancing and partly it is not enhancing. It is again showing diffusion restriction. Age of the patient is below 7 months. So it could be a pineoblastoma. To tell you, it could come from this location. Look at the first image of my slide. These are your internal cerebral veins, and there would be the pineal region. So it will come from this location and will cause swelling of the internal cerebral veins. So this is within the ventricle, very superiorly placed. Choroid glioma would be at the roof of the third ventricle, not within the third ventricle, and it will not show diffusion restriction. It is a low grade tumor, and this is definitely very cellular. This is showing diffusion restriction. Medulloblastoma, how can it be a medulloblastoma? Medulloblastoma would be in the fourth ventricle. This is in the third ventricle. Medulloblastoma is a posterior fossa tumor unless until you are getting metastasis superiorly. DNET is a cortical based tumor and generally does not show enhancement. Only in 33% of the cases you could see enhancement. A choroid plexus carcinoma is a good differential, but location wise, I would again rule it out. Epidermoid will not show enhancement. This lesion is showing enhancement. Yes, that's a very, very good differential, Kriti. Uh, Supratentorial ependymoma. So what happens with ependymomas, when they are infratentorial, they do not show any diffusion restriction. But however, the supratentorial ependymoma, they do not behave like the infratentorial one. In 85 to 90% of the cases, they show diffusion restriction, and this is a very, very good differential for this case. The final diagnosis was ATRT, but I would keep a differential of supratentorial ependymoma also in this case. Neurocytoma is again a tumor of young adults around 25 to 35 age group. Pilocytic astrocytoma is a grade WHO grade 1 tumor. It will never show diffusion restriction unless until you have got bleed within the tumor. Otherwise, it will not show diffusion restriction. Uh, uh, Choroid glioma can be a differential. Somebody has written. I am not just saying for you all. I am just reading. Choroid glioma is not a differential. It is in the roof. It is seen in adults. This is a pediatric patient. Craniopharyngioma, somebody has written no, it is not a differential, because generally what happens, there are two type of craniopharyngiomas. Edemantomatous, which is seen in pediatric age group, they are cystic with a solid mural nodule, and they have a very viscous oily kind of substance within it, giving a T2 flare bright appearance and enhancing mural nodule, and there would be some calcification also. Saga, Saga won't show diffusion restriction again, but unless until it has bled. Saga can bleed at times and it can show diffusion restriction, but Saga are generally formed by the age of 10 to 12 years, I guess. This patient was quite young, and that is along the foramen outside the ventricle, which is foramen of Monroe, abutting the foramen Monroe, and it can impinge into the ventricular system. This lesion is proper, the epicenter of this lesion is from the ventricle. Germ cell tumor. So regarding the germ cell tumor, you could have a germinoma, which there could be uh, two places from where germinoma can come up. One is spinal region and one is the stalk. So do you feel, is it coming from any of those areas, the spinal region or the stalk? No, medulloblastoma, no, please no. So let's go to the next slide. And then stock, you could say, but it wasn't coming from the stock. Honestly speaking, I need to go to more lower sections than this to show you stock. It was uninvolved in this case. Yeah, lymphoma can happen. And what was the age group of this of that patient? SM? Can you mention that for lymphoma? So yeah, so lymphoma is definitely Mets myeloma lymphoma. That's a adult tumor, considered to be an adult tumor. So this is a pediatric patient, but yeah, you can see a lymphoma at that location, and that will show diffusion restriction. It was a good differential, but the age group wasn't matching. So to continue with the same case, the lesion showed Mets in the spine, and as you can see, some of the lesions, metastatic lesions, they were not enhancing, and some of them had showed enhancement. Going to the previous slide again, see, part of the tumor is not enhancing and part of the tumor is enhancing. So you could get metastatic lesions just from the non-enhancing part of the tumor, and when they are small, you could miss them. So you need to run a heavily T2 weighted 3D sequence, or a diffusion spine imaging should be done in such cases, embryonal tumors. Now coming to the next case, now this is again going to create a lot of confusion. The patient is 4 years old. There is a mass in the posterior fossa which is showing a lot of diffusion restriction. So SM has got the diagnosis, kind of diagnosis. This is medulloblastoma. Yeah, Ankur has got it right. He has written medulloblastoma or an ATRT. That's a good differential. So this was again an ATRT, but was reported as a medulloblastoma, as this is quite similar looking as medulloblastoma. There is no hemorrhage. If you see, there is no necrosis within the tumor, but the only thing which was going against medulloblastoma is the multiple cystic areas, which are quite, like you can say, 4 to 5 in size. So medulloblastoma has small cysts within, like subcentimetric cysts within the tumor, but that's not the rule always. Generally, they have very small cysts within the tumor. So, uh, so saying it to be a medulloblastoma in this case is a good diagnosis, but this one came out to be a ATRT. The only thing going against was these cystic areas within the tumor, which were slightly bigger. A medulloblastoma would have these small cysts like these, the smaller ones. But that's not a very hallmark kind of point. You cannot differentiate this. So you have to write both the diagnosis in such cases. Lymphoma is not a diagnosis or differential diagnosis because this patient was just 4 years old. And again, we have discussed that lymphoma is seen in elderly patients. So this was a case of ATRT. All of them, actually, last 3 4 cases were of ATRT at different locations, which are embryonal grade 4 WHO tumor. They have loss of expression of SMARCB1 protein. They are mostly seen infratentorially and are seen below the age of 5 years, and can have leptomeningeal dissemination also. Okay. The one with the acoustic schwannoma, it's a cranial nerve. This guy had some dissemination. If you could appreciate in the Meckel's cave on the opposite side, there is a deposit sitting here, and on brain also there was some leptomeningeal enhancement seen. Now, let's go to the next case. 19-year-old boy with backache radiating to the right lower limb since 4 years. So everybody is writing it as myxopapillary ependymoma. Okay, some of them got it right. What do you see? Just see the plain P1 image in the center. They are writing ependymoma with T2 cap sign also. Okay. What is the cap sign about? That's the blood. So if you think that this is the blood, the cap thing, this is your fat suppressed contrast image. That blood has gone black. So is it a blood? That's the fat within the tumor, right? So this bright area, that is all the fat within the tumor. Yeah. So what is your diagnosis? Dermite or a teratoma? You cannot differentiate. It could be either of these two. Let's go to the next case. She is a 17-year-old girl with history of weight loss. Just try describing the lesion. What do you see? How is the lesion? Yeah, Ankur got it right. Yeah, irregular, very nice. How is the outer rim of the lesion and the inside of the lesion? Cavernoma, that's a very good differential diagnosis in this case. Very nice differential diagnosis. This was a case of tuberculoma. I showed you the first table. So you can see the T2 dark rim with central hyperintensity, and this is quite a shaggy thick rim. You can also see on axial, and this did show some kind of diffusion restriction within the lesion. So going back to our table, which I had showed you in the first case, coming to the third column, caveating granuloma with central liquefaction. Hypointense rim is seen on T2 weighted image with central hyperintensity. And it may or may not show any diffusion restriction, and it shows rim enhancement. So this is a tuberculoma. And you won't believe they did the biopsy of this case and it came out to be TB only. So this is again like a short case. Putting up the first panel, what do you think? What is your finding here? PHTV, choroidal melanoma, 39-year-old patient. Those who haven't found yet, the finding is here. There is retinal detachment with bleed. V-shaped detachment is the retinal detachment with the bleed. Now coming to the next set of images of the same patient. Now you tell me the diagnosis. Where do you see the lesions? Where are the lesions? Yeah, Sujay got it right. Cerebellum and the brainstem. On the pial surface, we see nodular solid lesions showing intense enhancement. And on the spine, there is again a lesion along the pial surface. So, what is the diagnosis? Yeah, that's right. That this is a case of VHL. What are the other findings you see in VHL? First, tell me the CNS manifestations. And why do we see this bleed within the eye globe? What is the reason behind that? Because these are the retinal angiomas which causes retinal detachment. So you don't really see the retinal angiomas, but you see the uh, retinal hemorrhage with retinal detachment, which is an indirect sign, and you can call it that a patient must be, if it is a case of VHL, you can call it that the patient must be having VHL, retinal angioma. Sorry. Yeah. So endolymphatic sac tumor is also seen in the brain. And what are the other findings in the body? Kidney, RCC, clear cell, pancreatic cyst, pheochromocytoma, pancreatic serous cyst adenomas, fibroids, epididymal cyst, very good, angiomyolipomas, pheochromocytomas, that's right, good. So mostly two-thirds of the cases have such kind of presentation. There is a cystic tumor with an eccentric neural nodule, and one-third of them have only solid lesions, which and the solid part comes on the pile surface. And also seen in our case, the solid deposit, the lesion was on the dorsal aspect of the cord. So, and the patient also had retinal angioma, which was seen as V-shaped hyperdense posterior globe. And there could be endolymphatic tumors also, which we have already discussed. Yeah. So yeah. So now tell me this one. Just read the history very nicely. Be careful. 40-year-old male with perianal ulcer since 8 months. 8 months had it 8 months back and took wind blasting. What is wind blasting? What drug is it? One episode of loss of consciousness and three episodes of seizures. What drug is wind blasting? You first tell me about the drug. Yeah, Kavan got it right. That's a chemotherapeutic drug. Yeah, Meghna, that's right. That's a chemotherapeutic drug. Now describe the findings. What do you see? Where are the lesions? Predominantly, they are located at some place, specific place. No, that's not breast. That's not lymphoma. Brainstem, that's right. And also, you can see along the temporal horns also, there are some lesions. So, yeah, that's right. Clippers. Clippers is a chronic lymphocytic inflammation with pontine perivascular enhancement responsive to steroids. Uh, there is a slippers also, which is seen in the supratentorium. It is said that the etiology is not known, but I just found an article just before this presentation. Punctate and curvilinear gadolinium enhancing lesions in the brain. Just have a read of this article. This is a very nice article. I have noted some of the important points from this article. Apart from the physiologic contrast uptake, you could see three pathological condition with punctate and linear gadolinium enhancement. That could be because of the small collateral artery network like seen in moya moya, small vein congestion related to developmental acquired venous flow disturbances. And this is our case, the third point, disorders causing small vessel disruption uh, of the blood brain barrier indicating T2 and flare hyperintensity with corresponding curvilinear and punctate like lesions in the pons. So this blood-brain barrier disruption could be because of the endothelial cell injury or could be because of the angiocentric cellular infiltrate. In the patients who have taken radiochemotherapy with posterior reversible encephalopathy patients, Suzak syndrome, clippers, as in our case, demyelination, many more, SLE and all. Yeah, thank you. Now, what is this? Similar kind of case. The patient presented it to us in January 24 and it was reported as GBM outside. Somebody wrote it as GBM. What do you see? There is some lesion on T2 which is not forming mass. It is very, it has got very melted, very speckled kind of appearance. Yeah, tumefactive demyelination, TML, HIV, lymphoma. Then you see lot of punctate kind of lesions and vascularity along the blood vessels. That is the angiocentric kind of vascularity along the blood vessels. Again, going back to the previous slide, There could be angiocentric infiltrates in inflammatory disorders like demyelination, post-immune response fighting against the infections, SLE, clippers, lymphoma. Slippers is Slippers का ऊपर वाला form is slippers. That is in the supratentorium. It is called slippers, and these could be. Um, we really don't have the diagnosis for this case. After 4 months, the patient was given steroids, and this is what we see. The lesions have come down, and you can see them. They're little so they can be traceable so nicely. They are like dot and dash kind of lesions which are resolving. It could have been a demyelination, SLE, or anything lymphoma. We don't know exactly what the diagnosis of this case could be, but you can definitely go and have a read on that article and be more wiser on this case. Coming to the next case, what is your diagnosis? This is a very simple case. No diagnosis till now. Lymphoma, why would anyone say lymphoma? RMS, rhabdomyosarcoma, no. What is happening to the bone here? It is expanding. There are multiple cystic areas within the tumor. Now you tell me what is your diagnosis? Yeah, that's right. That's FD, ground glass appearance in the bone. What are the symptoms associated with FD? What all symptoms do you know? There are multiple symptoms with FD. Fibrous dysplasia, Methunel, right? Megawatt, right? Good. Nice. Methunel, but yeah, that's right. So now you tell me these are two different cases. On the left is case one, and on the right is case two. What is your diagnosis for case one and what is your diagnosis for case two? If anybody wants to guess on this image, otherwise I'll go ahead with the cases. So meningioma, macroadenoma, how could be it a macroadenoma coming out of the fella like this with sparing of the pituitary? No. Craniopharyngioma, rat case, aneurysm, meningioma, carotid sheath tumor. These are the differentials which I have received till now. Okay. ICA, aneurysm, schwannoma, germinoma. Both are adult patients. Now to something. Meningioma. So coming to the case A. This is the entire set of image. Now tell me what is it. Yeah, most of you have got it right. So this was a meningioma. It was very intensely enhancing clinoid meningioma going to the planum. And what is peculiar about these meningiomas? Just see this area. This is your supraclinoid ICA on the normal side, and this is on the affected side. What happens with meningiomas? It encases it and it narrows the caliber of the lumen. However, it does not infiltrate it. If it would have been a macroadenoma, it will go around the vessel, but it won't narrow the caliber of the vessel. However, in meningioma, there is narrowing of the caliber of the vessel, and there could be a associated infarct in the right MC or ACA wherever it is going and causing narrowing. So somebody wrote it as meningiomas are not T2 hyperintense. It could be angiomatous any meningiomas, which is grade 1 meningiomas. So we have three grades of meningiomas. So grade 1 meningiomas, which are angiomatous meningiomas, are very T2 bright and they show this kind of intense contrast enhancement. Nobody has told me up till now the diagnosis for the second case. I have read all the differentials in the list. Somebody wrote it as lymphoma. No, it's not lymphoma. I would have definitely shown you the diffusion image to call it as lymphoma. So we did a dotapet of this scan because we were confused with some differential diagnosis which I won't tell you, and we confirmed that this is a meningioma and the surgeon could go ahead with that. If it would have been the other differential, which is the case B, So what is your diagnosis there? Hemangioblastoma, hemangiopericystoma, epidermoid lymphoma. Still, I'm not getting the right diagnosis. Esthesiosis, schwannoma, glioma. This is what coming up in the chat box, and I'm reading it. Schwannoma, giant meningioma. Okay, after small meningioma, I will show you giant meningioma. Aneurysm. Yeah, that's somebody got it right now. Who is that person? Somebody wrote it as cavernous hemangioma. So as you can see, this lesion is quite T2 bright, and on contrast imaging, these are the serial imaging. It is showing enhancement, then it is showing more enhancement, and then it is showing further increase in enhancement. Ideally, a dynamic scan should be done in these patients, and it will behave like a meningioma that with time the enhancement will keep on increasing. So this was a, and it on DotaPet it did show any uptake. So this was a case of a chordoma is in the central. You could have said a chondrosarcoma. Chondrosarcoma would have been a better differential for this case. This was a case of cavernous sinus hemangioma, and chordoma chondrosarcoma will have a arc and rim like enhancement and appearance. Yes, it would be very bright on T2. This was an adult case, so germinoma generally happens between 5 to 20 years of age. Why not a schwannoma? Schwannoma would not show so much enhancement. Now, this enhancement will keep on increasing since it's a hemangioma. Schwannoma and hemangioma will definitely have some different kind of enhancement patterns. Schwannoma are not so vividly enhancing. Why not an aneurysm? Because the vessel was not involved. It is not coming from the vessel. It is arising around the vessel. So in such cases, what is the treatment? IR surgery. So in such cases, yeah, I should have actually shown you. Radiation is given to these patients, and they show such beautiful response that after years, like after 2 to 3 years, if you do a scan, you will see nothing, no traces of any lesion. So radiotherapy can help these patients. And imagine if the surgeon opens this case, it would have been a big disaster. So it is very important you should differentiate these two entities. And a dynamic contrast scan should be done in cases of hemangiomas. Yeah, that's the same. SRS treatment is radiotherapy only. No, we don't do anything for different grades of meningioma because we don't believe in that. Even in grade 1 meningiomas, we have seen bone erosion, lot of contrast enhancement. We just leave it up to the pathologist to decide the grade. Fungal granuloma. Why on earth would you think of a fungal granuloma? That would be T2 dark. This is T2 bright. MR perfusion would help in this case. Definitely no, it will show very high perfusion because it is such a vascular lesion, so it won't help here. I'll go to the next case. He's a 10-year-old boy, and that's a video. You'll have to see that. It's like the case again. You see a mass, you see another lesion in the coronal radiata. Do you see something here? You see another lesion which I have put a pic of it, and then there was another lesion. I'll show you the video again. Just look at the first video only. Don't get into the diagnosis, please. All the diagnoses mentioned up till now are wrong. So I'll just show you. There is a mass, first finding. Okay. There is another mass, and there was a lesion in the corona radiata in the posterior limb of internal capsule also. I just flipped it. I'll show you again. Just look at the brainstem now. There is another lesion which will come up here, some bright area, not seen very well. So again, don't think of a lymphoma in a 10-year-old child. So this is a cystic lesion with some enhancement at the periphery, eccentric enhancement. Yeah, Megha got it right. That's the pilocytic astrocytoma. There is a lesion which was seen nicely. Just look at the first video again. Did you see this lesion apart from this lesion? And then over here around the aqueduct there is another lesion. PXA would be surfacing on the pal surface. Yeah, Anurag got it right. This is a pilocytic astrocytoma. And what are the other lesions? What are the T2 bright lesions which are not showing any enhancement? The other three lesions are, name them. What are they? They are Farsis, right? Abdul, that's right. They are Farsis, and this is a case of NF1 as already told by Anurag. So, pilocytic astrocytoma with multiple Farsis. So this you could read about NF1. They have plexiform neurofibromas. They have sphenoidal dysplasias. They have dural ectasias also. Why so much edema around the lesion? So edema is not any criteria in brain tumors to call it as a grade 1 tumor or a grade 4 tumor. Even a grade 1 tumor could have a lot of edema. That's not a criteria. Many people think that if there is a lot of edema around the lesion, it has to be something very high grade. That's not true. A pilocytic astrocytoma can also show edema around it. Pilocytic astrocytoma with multiple. What did you say, ma'am? I said Farsi. Farsi lesions are there. Focal areas of altered signal intensity. Farsi. They are nothing. Just that they are what can you say that uh, vacuolated myelin kind of thing which is quite benignish and they tend to disappear. That book says that it tend to disappear after the age of 10 years. However, uh, practically I haven't seen them disappearing after the age of 10 years. They may or no, that's not uveo. Uveo is unidentified bright objects. That is the cause you don't know. In this case, these are PASIs. These are myelinated vacuolated kind of lesions, and they are benign. They have a waxing waning course. They tend to come by the age of 10 years, and after that they say books say that they disappear, but however I haven't seen them disappearing. Fasties, somebody wrote it as, he's asking that are they hematomas? No, they are not hematomas. Hematomas are gray matter structure. Myelin is white matter. So there is a lot of difference. And Farsis, yeah, Farsis do not enhance. Can somebody just write the spelling of Farsi? Somebody wants to understand F-A-S-I, Farsi. Yeah, thank you, Vrinda. Thank you, Preeti. So now tell me what is the diagnosis? She's a 12-year-old girl presented to us in casualty. Focal area of signal intensity, yeah, in the thalamus, in the left thalamus. How is it as product like a carcinoma, papilloma? This lesion is coming out of the ventricular system, though it looks like it is within the ventricular system. Yeah, that's a good differential. By the way, thorax papilloma. Now I'll show you the next image. Now you tell me the diagnosis. So most of you have got it already right. That's the cavernoma, and that's the CT scan image. And just go about the classification. Just read the classification. There are four stages of cavernoma. This is one of them. This is stage 2. Yeah, Akshay, that's right. That's stage two. Very good, Priya. Tell me your diagnosis. This is next case. This is a very easy. Yeah, so Bhuvan, that's right. I just forgot to tell you, it has got a popcorn-like appearance and it has a hemocysteine rim very well seen on T2 weighted image. Abhijit wrote it as dengue. Dengue will be mostly bilateral thalamic involvement and the posterior brainstem involvement will be seen in dengue. This is unilateral and this is showing very intense enhancement. It is T2 dark. There is some edema. No, it's not toxoplasma. I would have given you the history of HIV. This is just a case of a tuberculosis, tuberculoma, conglomerate lesions showing intense enhancement and they are all conglomerated. That's a tuberculoma. Good fight. Ruptured cavernoma, somebody thought it as. The case has changed, Kajal. It's not the same case now. This is the second case of thalamic lesion. This is a slightly tough case. 38-year-old man with left-sided proptosis since 20 years now and has multiple hypopigmented patches. Now you see the findings. There are some T2 dark nodular lesions in the cavernous sinus. Tolosa Hunt is a condition. What are your differentials? Oculomotor schwannoma, thickened nerves. That's a very good finding which you have picked. These are thickened nerves. Yeah, these are like three or four nodular areas seen in the cavernous sinus, and these are all thickened nerves. Nerve thickening is seen in which cases? Yeah, right, but I want to wait and see. So, sarcoid, leprosy, neurosarcoidosis. Why is everybody so sure about leprosy? Hypopigmented patches on the skin because of that. So that's the right answer, leprosy. But what are the cavernous sinus lesions? Can you just mention them? T2 dark lesions. What are the other lesions you see here? Neurolymphomatosis. In leukemia also you can see some deposits. Then Ardent, IgG4, Rosad Hoffman. You tell me the differences. Nobody's Lyme disease. Yeah. Keep telling the differentials. What are the differentials? Tuberculosis. Yeah, Abdas is right. Arjun, herpes, IgG4. Very good. Tell me more differentials. These are what I have already told you. Herpes. Okay, so this was a case of leprosy and hypopigmented patch on the skin was the clue for this patient and he has such a long history, like 20 years, 19 years. This can be leprosy and nothing else for such a long period of time. I think that's my last case. Yeah, and we are ending the time also. So yeah, tell me, what do you see? 14 years old boy. Where is the epicenter? Where is the lesion? First you tell me the epicenter. Where is this lesion located? See, over here, the internal cerebral veins are splayed. So where is it located? Yeah, pineal region. Very good. Some of you have already got it right. So the region is very bright. It is showing diffusion restriction and it is not showing any contrast enhancement. So I would just address what are the wrong answers being typed here. Pineoblastoma. See, first of all, pineoblastoma wouldn't appear in a 14-year-old child. It is a very early childhood malignancy below the age of 5 years, right? So this is not a pineoblastoma, and pineoblastoma will definitely show enhancement. Being a round cell tumor, it will show diffuse restriction also. Now somebody wrote it as germinoma. Germinoma will definitely show diffusion restriction, and it will definitely show contrast enhancement also. ATRT, no, I'm done showing you all ATRT now. This is a 14-year-old child, so ATRT would be seen in 5 years and below 5 years age group. So this is a epidermoid. So most of you have got it right. Very good, excellent audience. So, pineal epidermoid is quite a rare location, and generally you see epidermoid in the cerebrolpontine angle, suprasellar region, and the age of occurrence is between 20 to 40 years. That was my last case. Thank you so much for your patient listening. You are a lovely audience. Thank you and enjoy your match.
Thank you. Thank you so much, Arpit. It was such a good case collection. I think it's really amazing case collection which you have. Uh, and I think everybody was not watching the match for sure because we had so much responses here.
Yet,
So,
yet to start now. It's at 8 o'clock, I guess.
right, so you finished on time.
And hopefully, I won't be getting any more questions now because everybody wants to watch the match.
Yeah, but I think they have put in some questions during the cases in the Q&A section. I think most of them you have answered, but can you have a
Okay.
look? Few people have just put in the
Yeah,
answers
yeah.
also over there.
Yeah. I didn't open this folder, so sorry. Yeah. Mm, so vagal nerve schwannoma, this I have already told you. If it is causing staying of the of the common carotid artery and the internal jugular vein, it will be a vagal schwannoma. If it is displacing both the vessels laterally, then it will be a sympathetic schwannoma. And I have shown you the diagram also. And what was skull base lesion? I think so. You are asking about ATRT, fifth cranial nerve ATRT. I am not really sure. How do we keep an RMS as a differential when there is no skeletal muscle involvement in the case? Yeah, so there has to be, so there are three types of RMS. I'm not sure if you know. So there is a parameningeal RMS, non-meningeal kind of RMS. So a parameningeal could creep along the cranial nerves, but yeah, it will have some kind of solid component and it will have a skeletal muscle involvement. But you can see a lot going across the nerve roots, secondary involvements across the nerve roots and at quite a small age. Now lymphoma, pituitary, microadenoma. Pituitary microadenoma, we perform dynamic scans, and what happens, as we all know, that pituitary gland has got no blood brain barrier, so it enhances vividly, and the microadenoma is hypoenhancing. It is hypoenhancing, and it will show enhancement on late phases when the pituitary enhancement is almost reduced. MR spectroscopy we don't do for meningioma. It is said that you can see alanine peak, but however, for extraaxial tumors, we are not doing any MR spectroscopy. Is there abnormal signal in optic chiasm on the right side? I am really not sure what case you are talking about, but there wasn't any lesion. It's not done in meningioma. I am saying dynamic should be done in cavernous hemangiomas. It will show enhancement like an hemangioma, delayed enhancement. Filling up gradually will be seen in hemangioma, and meningioma shows mother-in-law kind of sign on angiography. comes early but goes late. That means the enhancement comes early but it shows a plateau for a long time. It stays for a long time. The enhancement in meningioma. And in hemangioma, the enhancement keeps on increasing gradually as you see the puddling of contrast from periphery to center in the liver hemangiomas. It is the same in the brain hemangioma also. Lesion in thalamus. So you should read an article about unilateral and bilateral thalamic lesions. I'm not sure what you are asking here. Please show ATRT case again. I have shown you multiple, 4 or 5 cases. I'll show you again if you want. What is the clinical significance of FASI while reporting? It is just to clinch a diagnosis of NF1 on radiology. However, it is quite a benign finding and has got no clinical significance or implication. And you don't have to treat or you don't have to do anything to it. You don't have to operate it. You don't have to radiate it. Just leave them alone. They will go with time. They are kind of self-resolving lesions. Thalamic hyperintense lesions you had shown. That thalamic hyperintense lesion was a cavernous cavernoma which had a popcorn-like appearance. You missed some of the cases. Can I repeat? So, is there any abnormal signal in the optic chiasm of the leprosy case? So, I'll show the PPT again, Ankita.
No, I think if you'll
So,
give permission for the recording thing, then they can go back and
okay,
review the.
okay, sure, sure. Okay, sure. Okay, okay. Yeah, thank you then.
Thank you so much. Thank you
Yeah,
everyone for
thank you.
being
Bye bye.
so good audience. And as usually had a very amazing session today. So thank you,
Thank you
Arpita.
so much.
Hope to have you
Thank
back.
you so much.